For case 9, we have a patient with a seizure and history of HIV. Here we have 2 axial flare images through the cerebral hemispheres. Now we have the associated post-contrast imaging. Finally, we have some diffusion imaging. So we have diffusion-weighted imaging on the left and the corresponding ADC on the right. So just think about that diagnosis for a second. Again, your question is, what is the most likely diagnosis? Your second question is, what is the mechanism for elevated diffusion intensity in this lesion? I'll give you a second to read those answer choices. So in this case of this patient with HIV, we have an abscess. Here you have ring-enhancing lesions with various amounts of surrounding edema and reduced diffusion. The most common locations where you're going to see these are at gray white junctions. And as this kind of goes without saying, that immunocompromised patients are more likely to have these. So HIV, transplant, and immune suppression for MS or rheumatoid arthritis. The other thing that you have to think about is intravenous drug abuse. When you have multiple ring-enhancing lesions in an immunocompromised patient, this needs to be your differential diagnosis. You need to think about abscess, metastases, toxo, neurocysticercosis, and lymphoma. Now, diffusion can often help you differentiate these. Mets, toxo, neurocysticercosis usually do not have abnormal diffusion. Lymphoma can have abnormal diffusion, but the pattern tends to be different. It tends to be the areas of solid enhancement have abnormal diffusion. So they'll be solidly abnormal diffusion or have a peripheral rim abnormality, whereas abscess tends to have the diffusion abnormality centrally. Here we'll just review the images from this case. They're parenchymal abnormalities. So you see in the right temporal lobe, you have some abnormal flare as well as kind of the left parieto-occipital region. If you now take a look in those same areas, you have corresponding enhancing abnormalities. So you now have multiple parenchymal ring enhancing abnormalities. And when you look at them on diffusion, what you see is that the diffusion centrally is reduced. So it's very bright on diffusion-weighted imaging here, and this is correspondingly low on ADC. So that's the pattern that you tend to see with abscess. Now for your second question, the mechanism of diffusion being abnormal in this case is that the pus is very complex fluid and restricts the motion of water. Now these other things tend to be also cause abnormal diffusion. It's not the case for this patient. D would be theoretically describing neurocysticercosis, but those typically do not have abnormal diffusion. And this is the definition of T2 shine through, which is not the case.